The Dentalpreneur Podcast. Okay, doctor, it's time to put down that handpiece. You're listening to the show dedicated to helping dentists get their lives back. It's time to decrease your stress, increase your profitability, and regain your passion. Now introducing your host, Dr. Mark Costas.
Hello, everyone. Welcome to another episode of the Dentalpreneur Podcast. I'm your host, Dr. Mark Costas. What is up, my friends? Fun day today in store for you guys because I get to hang out with a good friend of mine, Dr. Taher Dhoon, who's a co-founder of the Colorado Surgical Institute. He is a very successful practice owner in Greeley, Colorado, and he's a DSI Black Belt coach. How you doing today, Taher?
Doing great. Just hanging out at home and working on a little bit of Colorado Surgical Institute infrastructure and getting to record a podcast with you.
Nice, dude. Nice. So we just are hot off the heels of another successful September course, our biggest one yet there at Colorado Surgical with over 100 students / attendees. Some were dental students, but mostly doctors from all over the country that came in and were doing lots of different types of procedures. Some people came in just for lateral sinus and block grafting. Some came in for full arch. Some came in for wisdom teeth. Some came in for onesie and twosie implants. So the course was filled with lots of different types of procedural, focuses. So it wasn't just full arch this time. So tell me how the flow of this course was different with the breakout rooms and all of that stuff, and just a little bit of reflection after action report from this most recent event.
It was a really great event. The one thing you did miss was we also had 4 IV sedation docs there.
Oh, okay.
So they were going room to room and sedating people also and getting their reps and their live patient reps for their respective state boards. Mm-hmm, mm-hmm. But it's been a really cool evolution. I was searching through some old pictures the other day and kind of seeing how we ran things back in the day to where we are now. And we started in our 6 operatory practice and, a small little reception area room. Like we could maybe jam, like you would be sardines in a sardine can and we'd get like 20 people in that reception area. Mm-hmm, mm-hmm. And then now we've scaled up to 12,000 square feet. We have one conference room that can hold 60 people, maybe like 70. And then we even still had standing room only when we had everyone in that room. And we have another breakout room where it's about 40, 45 people can be in that room. And it's really cool because I thought when we were building the place, like we built it too big. And then all of a sudden, fast forward, 8 months from moving in, 10 months from moving in, and the facility is packed again. So it's been a really cool experience to see that, the planning that we put into it years ago is all paying off. Yeah. And so since 3 years ago to today, like we're restructuring the whole thing. We have these breakouts, like you mentioned, from 7 to 8 o'clock in the morning. And it's just different topics. So if you're an early riser, you want to come in and get extra education, we have breakout rooms where we talk about IV sedation or how to do PRF or phlebotomy with platelet-rich plasma in your practice, or platelet-rich fibrin, however you like to call it. We have one where it's a whole digital workflow. We have one where it's case planning. That one was a really cool one. Dr. Brisky put together an awesome presentation on, how he plans his cases out. He is so meticulous with how he does his surgery. He really is. And his surgery before when he plans it and his surgery after when he's done. I feel like if you put a mirror image and you overlaid them together, they would overlay perfectly. And he's doing everything freehanded. So it's cool to see how he plans all that out. And then I'm more of a freestyle planner where I'll kind of generally put implants in general locations and I'll start the surgery and I'll just kind of flow with it. So we have all the mentors have a different workflow, and we like to teach those workflows during the case planning pregame. So that part was a lot of fun.
Yeah, man, it's awesome. So just to paint a picture for everybody that's out there, what's the square footage of the total facility, and how many operatories do you have up on the surgical or up on the clinical floor?
Yeah, so the total square footage is 12,000 square feet. It's 2 floors, so 6,000 and 6,000. And we had to dig the basement real deep to get 10-foot high ceilings, so it doesn't feel like a basement. And we have the conference rooms and the labs in the basement. And then up top, you go, all the operatories are up there. And we have a set of operatories that are larger for surgery. And we have a total of 17 operatories up top. And I believe an 18th that's just used as storage. Actually, no, I'm sorry. 2 are used as storage. So we have 16 functional operatories up top, and then 2 ops that are just storage right now.
Got it. Awesome, dude. It's pretty incredible. I mean, I've talked a lot about Colorado Surgical and what great things that are happening there. What I really like more than anything that I think is second to none as far as other teaching facilities is our ability to work up the patients, pre-screen them for, the appropriate doctor and, kind of work with the patients on what they are seeking as far as clinical needs, so that we're able to kind of triage and filter those patients into the course. And also what's really, really incredible is the post-op care that they get, which I think is overlooked in a lot of different surgical environments, surgical learning environments. And we really, really focus heavily on post-op care for all the patients.
Yeah, I'm really proud of what we do there. So we have a resident. His name's Dr. Colin Myrick. Dr. Colin Hirsch. Sorry, Myrick is a DSI, gangster. Yep. But we have Dr. Colin Hirsch, who is from the Jacksonville University implantology program, and he's helping with the post-ops. It got to the point where we had so many post-ops that Dr. Brisky and myself couldn't take care of everyone to the level of care we would a private practice patient. And so now we have a resident that's there as well. And man, like the cases coming out are phenomenal. They're beautiful. I almost want to open up a course where it's just like delivering the final arches on these patients, so the attendees could come back and see like what this impact means when everything is said and done. They have their sleep appliances, they're oxygenating better, the teeth are in, they're just in a hygiene protocol. So yeah, the systems and everything we have in place are basically what we use in private practice. And every patient that comes through the institute is basically treated as a private practice patient.
I love that. That's so unique, actually. One of the things that we were talking today in our after action kind of meeting, leadership meeting, CSI meeting, was some of the complications that occurred during the clinical aspect of the course. We have didactic, we have clinical, we have hands-on, we have mentors always looking over the shoulder of the attending doc or the doctor that is there to learn. But inevitably, in a clinical setting, you're going to get complications. And, one of our words of the year, in fact, I have it on t-shirts now, from last year was equanimity. And that is the ability to handle yourself with poise under stressful situations. And a lot of times when you are expanding your clinical suite and your clinical skill set, you're going to end up in situations that are complicated. Sometimes you feel like you're a little bit over your skis when you're new to a particular procedure, and sometimes things go sideways. But your ability to remain poised and handle those complications and difficult situations is a huge part to getting through those with minimal brain damage, I guess we could call it. So maybe you could tell us a little bit about some complications that occurred in this last course or previous courses and how they were handled by the doctor that was the mentor and the institute in general.
Yeah, I'm glad this is the direction we're going to take the podcast today, because I think oftentimes what happens, via social media or via just whatever, friends talking about their cases, we really only share like the massive successes.
Yeah.
And little is talked about, like, hey, here's where I crashed up into the bricks, or I hit a brick wall, if you will. And so I'll share a couple of my complications, and we'll talk about some of the ones that happened during the course. And I think this is what causes a lot of doctors to get started and then to shut down the whole program altogether and never try again.
Right.
Is when they feel like they're the only ones this is happening to. And that's not true. Everyone's going to have a complication. It's just, is it minor or is it major? And the vast majority of them are going to be minor with good planning ahead of time. And that's where mentors and courses and different things come into play, is because then, like for the attendees that contact me and Dr. Brisky, beforehand, and we talk them through their cases. When we look at their x-rays, we look at their case, we're saying, hey, here's like the 10 things you need to watch for in this specific case. Mm-hmm. So they're already aware of the issues before they start. Mm-hmm. So anything that could have been a moderate to major ends up being a mild to moderate. And then they're at least prepared for it. Mm-hmm. So for example, we had one case where, we were extracting a failed bridge from 6 through 11. It was 6 and 7 were retainers and 10 and 11 were retainers. Okay. 8 and 9 were pontics. Super high smile line, super high smile line. So it had to be placed. The implants had to be placed deep enough and at the right location so you can get a good emergence profile, the gingival zeniths and all that fun stuff at the right location. Mm-hmm. And it was getting referred to us by a private practice dentist in Colorado who's really good, who's really good at what she does, and her expectations of what we give her are going to be high as well. Mm-hmm. So I get in there, and all the implants are just slightly flared buccal. So all the coronal part of the implants, if we were to look at this, we'd be screw holes coming through the facial of the implants. Okay. And they were immediate implants, and there's not a lot of places to go, because the wider you place your implant, then it gets closer to the adjacent teeth, it gets closer to the adjacent implants. And there's just certain rules and regulations you got to follow with placing implants close to adjacent structures. Yep. So what we do first and foremost always is take a surgical timeout. We took everything out of the patient's mouth. She was intubated. She was sedated. Check with anesthesia. Make sure anesthesia is good to go. And we just brainstorm. We're like, okay, we have implants with decent torque, but they're in the wrong location.
Now, these were placed somewhere else?
No. These were placed. So this is post-surgical. I walk in the room.
Got it.
Done
okay.
At the course.
Thank you.
And it's just when the implants went in, sometimes in extraction sites, they go in and they flare buccally because the extraction site guides your implant.
Yep, that makes sense.
And so we just did a quick surgical timeout, and we're like, okay, do we take a bird in the hand and say, this is restorable? Everything is going to be cement retained, but it's restorable, and send this back? Or do we attempt to fix it and fix our angulation, but we might lose stability? And if we lose stability, then we're doing cover screws. But if we do cover screw in an immediate extraction site, well, then all that tissue has to granulate in over the top of the extraction site, and we might not get full closure over a cover screw. And then that's when you get little microscopic, bacterial migration in, and you can get crestal bone loss. Okay. Mm-hmm. And so as we run through the scenario, we're like, okay, you know what? This is a learning environment. Let's go ahead and see what happens. Because I wanted to show people, if we lose stability, how are you going to handle the next step? Right. So I took the implants out. I moved the osteotomies more palatal, and then I replaced the implants in the right location. And that only takes about 7 minutes or so to do that. But we lost torque. Mm-hmm. So there's no torque. Yep. And I think the beauty of the Neodent system is they have an implant called the drive implant, where all the threads are trapezoidal, so they're all compressive. Mm-hmm. So we took out all the 4x13s, and I was like, all right, guys, watch what's going to happen when I place a 4x18 drive in here. And so we placed 4x18 drives, and we had plenty of running room. So thank God she had extra bone, right? Because sometimes you don't have an option.
Yeah, thank goodness on that.
And we torqued every implant out. It was beautiful. So everything went in the right location. We were able to just redirect these implants. But I think all of that goes to say is we could have settled for a lesser quality of a product and referred this back to our doctor and had them kind of cursing us a little bit when they're restoring it. Mm-hmm. Or we could work through the scenario of, hey, let's redirect these things and troubleshoot, soft bone protocols. And so it was a successful outcome. And not all complications are handled perfectly, but at least that one was handled in a way that it's going to save everyone hours and hours of prosthetic time in the future.
Wow. That's a really cool example. So did anybody else pick up on the fact that the coronal aspect of those implants was a little bit too far buccal, or was that something that you came in and noticed after they were all placed?
So it's easy for me so imagine, there's 12 rooms running, and we have a mentor in every single room. Mm-hmm. And then I'm going to hop in from room to room to room. Mm-hmm. So it's almost like you're playing speed chess at the park, and there's one person playing 12 games. Yeah. But I get to come in and I get to nitpick the crap out of everyone's thing. Okay. And I think I do that from a perspective of trying to educate, like even if it's 2 degrees off, I'm going to point out all these little small things so people can at least just see what I'm seeing from a bird's eye view. Mm-hmm. And so the mentor in the room knew they were a little bit facial, but knew that we drifted and knew that we were going to lose torque. And so when I came in the room, they helped point that out for me as well. So I saw it and then they pointed it out. And then we discussed the case together. And so it was nice to have like the mentor in the room, obviously like understanding what was happening and be aware of it, but also knowing the ramifications of this might have to be a cover screw case if we fix it. So then when I come in the room, we get to talk about it together.
Yeah, that's very cool. That's very cool. Any other notable complications occur in this or past sessions?
This was a good one. There wasn't anything too out there in terms of like, okay, well, like, that was unmanageable. But one of the ones that really bugs me still to this day is one of my own I did in private practice. And so everything is fine. I'll start there because, the stories, it gets interesting. But so everything that could go wrong on this case went wrong. And every rule I had, I just didn't, I didn't enforce the way I should have.
Okay.
So my associate is running a sedation case. And he's doing wisdom teeth on a 21-year-old girl,
okay.
But super, super small, super petite, and it's an afternoon sedation. And so she's NPO in the afternoon, which means, she's dehydrated. Mm-hmm. And he already has her hooked up on the monitors. He already has her halfway through the sedation. And he's like, yeah, I can't really get her to the level I'm comfortable getting her to get her through this. Can you come in and help me with the sedation? And help me finish up the wisdom teeth quickly so I can wrap it up because she just needs to finish. Mm-hmm. So I come in and I say yes, and I hadn't done any of my pre-op, right? It's not my patient. I come in just to help out, and she's already tachycardic because of the procedure, but for whatever reason she's hypotensive. Like, so her blood pressure is really low, but her heart rate's really high. She's dehydrated, and she's this like small little thing, petite girl, and they're already giving her a lot of meds, and most of these meds are going to decrease blood pressure. And so from that perspective, I'm like, okay, I'm pretty quick at what I do. I can get her through here. So I drop my meds. I kind of do my little surgical timeout. I make myself familiar with the room. But one thing that I didn't do is radio over to the team and say, hey, I'm in a situation that's harder than normal, so leave me alone. And so when I'm administering the meds, someone's in the room asking me a question, and it breaks my concentration. And so I was only supposed to give, let's say 5 of Precedex, right? For example purposes. And by the time I looked down at the syringe, because someone was asking me a question and I was administering meds and trying to listen to someone, I looked down and I had pushed 20. And so, yeah, she had 4 times the amount of Precedex, and it's going to decrease heart rate, but it's going to floor her already hypotensive, blood pressure. And so the IV line also was like really close to the vein. So I couldn't pull the IV out of her arm. So the meds were in almost as soon as I had pushed it versus using an IV line that was higher up.
Sure.
So maybe a different line would have been helpful to buy me some time to just clamp the line if I accidentally administered the wrong thing. But that wasn't the situation, I had in that scenario. So I know the meds are in her system. I know I'm going to see this all start reflecting in about 2 minutes. And so I kick everyone out of the operatory except for me and the doctor and the assistant. And I just start running through. I was like, all right, like immediately turning off emotions and just going into problem solving mode. And I get the emergency kit. And for whatever reason, and this is like a perfect storm of shit, right? Mm-hmm. The anesthesiologist the day before or whatever had used my ephedrine.
Oh, no.
And so I didn't have ephedrine in the room. And so, I didn't want to use atropine because atropine feels like there's an elephant crushing your chest. Mm-hmm. And it's going to overcompensate. It's like, atropine is like using a bazooka if you just need a gun. Mm-hmm. So I'm looking through and I'm like, okay, what else is going to help me out here? And we had glycopyrrolate and we had phenylephrine. So like, okay, drop the phenylephrine, et cetera, getting everything prepared. And just watching the monitor, because I know what's going to happen and I know how I'm going to combat it, but I just don't know how long it's going to persist for because Precedex is going to stay in your system for a long time. And it's an afternoon sedation and it's already run long and I'm already called into the room. Mm-hmm. And so, I mean, dude, she plummets. She plummets to the point where I was scared. I was like, okay, I'm going to call EMS.
Mm-hmm.
And then I punched the phenylephrine in there, and it brings her back up, but it brings her back up really high, really fast.
Mm-hmm.
It's like, she starts getting a headache, starts getting a little nauseated. And then over time, the phenylephrine wears off, but then the Precedex and all the other, sedatives are still in her system. So then she just starts bottoming again. So I got to push phenylephrine again. And we just do this dance. I gave her 4 liters of fluids. That's how long she was in there. I gave 4 liters of fluids to her while I was administering meds to kind of keep her balanced. And yeah, I don't really get scared that often, but like I was scared. I was just like, okay, ran my scenarios. I know I can manage it, but all of that could have been very easily avoided if I had just followed the rules of what I teach in sedation, like what me and the anesthesiologist will teach the students in sedation, where it's like, if you're administering a med, you can potentially just draw up what you need, right? Most people don't do that, but they do that in pediatrics a lot, because with pediatrics, if you overdose, like it can be a really big problem. And my mom worked with pediatric oncology patients her whole career. So you can draw up what you need. And so that way, if you accidentally push everything, well, that's only the dose you were going to give anyways.
That's right.
Have a different line, make sure you're the one who does the intake and completes the sedation on your own patient. So then everything from start to finish. So there's a lot of moving parts, but that one is one where it's like, hey, you got to respect sedation. If you're going to do sedation in your practice, you got to have rules, and they got to be like rock solid rules to like follow.
Yeah. Wow. That's a scary one. I think that anybody that's done IV sedation has either heard a story like that or actually experienced something like that. It is very predictable until it's not, right? And then when something like that happens, it's so important. Just kind of like the whole focus of this episode is to maintain kind of your equanimity and your poise when something goes sideways. I really like that one a lot. There was a couple situations when we had root tips kind of in the sinus, and lost last session with Michelle, lost an implant into the sinus. And it was a lot of fun to kind of watch her demeanor when that happened, how calm she was, and matter of fact, and she's talking everybody through kind of what she was doing to retrieve it, how she had to lean the patient's head forward to get, the implant off the back part of the sinus and move it forward so that she could reach it with her suction tip. And that was another one that I was just kind of watching her demeanor, and something that would have probably caused quite a pucker in a new implantologist, and she handled it like a champ. That was fun to watch as well.
That's a really good point to touch base on. I think good teachers, even in situations, that's like the sign of someone with experience and who's qualified and who's dealt with it before. So if you can stay calm, your team will stay calm. And so my team, like, they were just following directions. They knew by my face when I kicked everyone out of the operatory that I was like, okay, this is going to get real. But at the same time, I called my plays out. I was very direct and very just matter of fact about what I needed in that moment. And everyone just got everything done. And so that's what I think is important. Like, sometimes you're going to be called in that operatory to be the leader, like Michelle was in that moment, and just guide people through it and not have an oh shit moment in front of other people.
Yeah.
And I think that's the cool thing about our mentors. And what we can do at CSI is the mentors are at a level where when an oh shit moment happens, they can have their own surgical timeout in their head, and then do that privately, and then walk everyone through it from an experiential performance or experiential perspective, so they can see how to manage these things in real time.
That's such a cool message. Listen, I want to expand this just a little bit to leadership, right? So a lot of people listening to my voice right now and yours are CEOs of their dental practice. They're the leader within their dental practice, whether they're, a lead assistant, an office manager, an associate, or the owner of the dental practice. Leadership is very, very important, right? And I can say this, that I've messed this up more times than not. Even late into my career, was not being able to maintain this type of poise and emotional control. If that's, not being able to contain your stress or your anger, or or anything like that, we are constantly faced with these challenges as the leader of an organization. You have always impressed me with the fact that you have a very calm demeanor when things feel chaotic and scary. This is a perfect example of kind of your demeanor. How have you developed as a leader in that area of emotional control and dealing with humans? Not just in a clinical setting, but in just an overall practice management setting.
Well, I appreciate you saying that. And I feel to some degree that I'm consistently working on it, even to this day. Mm-hmm. And it's just, you fall short, and maybe through experience and through the years of doing it, you just fall short less and less as time goes on. Mm-hmm. So I'd say a version of doing surgery and doing complex procedures has definitely helped me hone that skill set more, because if you're consistently in stressful situations, so for example, here in Colorado, we have the 14ers, right? So it's just very thin air when you get up to 14,000 feet elevation on certain hikes. So it's one of those things. It's like you continuously push yourself to go higher and higher up the mountain. And a lot of people have trouble breathing. But at the same time, when you acclimate to it and you get used to it, it's just this other thing that you can tap into. So I think by doing surgeries a lot in my career, it's allowed me to be in more stressful situations more frequently, which has just helped me kind of grow that muscle. And then two, I think I've been blessed to have a lot of people around me in terms of team members I've hired who have, felt safe enough in the situation to give me feedback when I did fall short in their eyes. And when I did say something that maybe was not in the way I meant to say it. I wanted to say something, but then the message I gave them was something else. Mm-hmm. But then they were able to reflect that back to me and say, hey, when you said it this way, that's where you kind of, insulted or you hurt my feelings or whatever negative emotion was attached to it.
Yep.
Versus, I know you meant it this way. So we were close enough to have that conversation where they could really help hold the mirror up for me so I could kind of improve. So I think having people in your life that you empower to give you that type of feedback is huge. It will level you up in ways that I never thought was possible. To have like Chris in my life or Michaela in my life, or even like a Dr. Brisky, or you. Now, obviously, now I'm in like, colleagues and mentor type of conversation, but it comes from all angles. Even John Hahn, one time, I still laugh about this. John, one time I was speaking and he came up to me after, he was like, man, it looks like you put on a little bit of weight. Like you've been letting yourself go a little bit.
Oh my goodness.
And I was, I took stock and I was like, oh, John, like, okay, that was super direct. But at the same time, I was like, man, like I'd like having people in my life who would tell me that. Like if spinach is in my teeth, they're going to tell me spinach is in my teeth.
Yeah. Yeah.
So it was nice. And so sometimes when I'm moving some weight now, I think about John still to this day. And I was like, I'm appreciative that he was able to call me out on my stuff. So I think having friends in your life that give you honest feedback and they care more about your personal growth than they care about your feelings sometimes is nice to have.
It is. And it's interesting too. I mean, we're talking about these scary clinical situations when poise and clear-headedness is really important. But whenever there's something happening in the practice or, when the leadership team is assembled trying to deal with a particular challenge or something, you can almost feel the eyes kind of looking at you like, how's he going to react? And, if you're a strong leader, you recognize that and you do your best to control your emotions. Viktor Frankl's always in his seminal works, Man's Search for Meaning, he's talking about the importance of controlling that gap between stimulus and response, right? So we can't control the things that are happening externally around us, but what we can control is our response to those particular situations. That's why I think like meditation is so good, because you're gaining more control over that gap between stimulus and response, and just being in the trenches and in a leadership position long enough to know that, hey, look, if I lose my shit right now, and I lose my temper or I freak out because this is a scary situation, the team is watching. And that by definition makes you not a strong and respected leader if you can't control that gap. So, I mean, it is definitely an ongoing kind of process fine tune and get better at controlling that gap. But it comes down to so many different things, right? Like somebody attacks me online or on social media. Like I have the ability to snap back immediately and cause, an armchair quarterback war on social media, or I could just kind of put it away and recognize that they're trying to get a rise out of me and let it go. Or I could be offended by somebody and I could snap like an angry text at them in the heat of the moment, or I could put my phone away, let my emotions kind of settle down a little bit. And then if I still in 24 hours feel like I want to shoot that text off, then I'll do it. But when calmer heads prevail and you're able to control your emotions, I think that it really is the beginning of a sign of a really strong and true leader.
Yeah, I'm glad you brought that point up. A way someone explained it to me that I've been doing, but I just subconsciously do it now, is they said break it apart into three things. So when an event happens, look at your physiology first and say, okay, what's happening? Okay, my heart rate's elevating, my pulses, like I can feel the vein in my forehead is popping out. Mm-hmm. Like what's happening to me on a physiologic level? Two, it's going to be like, okay, emotionally, what am I feeling? And like start to like separate out into different like categories, what's happening to yourself and to what's happening to your body. And then three, what's the story that's happening right now? And so the story could be like, okay, yeah, in the leadership position, yeah, my team is mutinying or whatever. Or the story could be, hey, they're here having a conversation with me because they care deeply about me and they want this to work out. And it's so interesting at how if you reframe the story of whatever conversation it is, it can 100% change the outcome of that scenario.
Yeah. Yeah. Wow. What a cool conversation. I like how it went from clinical to overall leadership. Some of the topics that I love talking about.
Right.
But that was really cool. I appreciate you, man. I want to congratulate you on, this steady growth of your dental practice. Congratulations there, of the successful integration of CSI into this beautiful new facility and the growth of CSI as well. And I got to say, dude, like, you're becoming a very, very well-known and rightfully so surgeon in the United States and a respected speaker. So I'm glad to be affiliated with you, and I'm really happy to see that the development of CSI is in large part due to the continuing improvement and development of you and Dr. Brisky as surgeons and speakers. So congratulations, dude. It's really cool to watch.
Yeah. Thank you so much. I really like that you've been here for the entire journey, and that all of this started with a phone call I gave to DSI way back in the day in like the end of 2017. Mm-hmm. It's really cool to see with intentionality and good guidance and big ideas, what can happen over a very short period of time. Now, granted, 8 years is not that short a period of time, but it's still in the big scheme of the journey. It's a short period of time. So, I think surrounding yourself with good people really, really helps. So I appreciate all the guidance through the years, Mark.
Oh, of course, dude. It's one of the great blessings of my life, right? I got some gray hair and I've been doing this for a minute. This is my 13th year working with high-level operators. And to be able to tell the evolution story of so many people, like you're just one of many that, like, I remember you didn't know how to read a P&L when you and I got on our first phone call, and you didn't know that your overhead was elevated. Didn't know if you were producing the appropriate amount for a practice your size. You didn't know any of that stuff, and now, I mean, it's just really, really fun to watch how far you've come. And I don't mean to sound condescending in any way. It's really a cool thing to be, a coach and a cheerleader on the sidelines, just watching you crush it. So, and I have the ability to and the privilege of being able to watch so many of these types of stories unfold. And, that success leaves clues, and there's consistency amongst the behaviors of the people that overachieve. And it's fun to be able to drill down those common themes of people that are super successful and share them with everybody.
Yeah. Well, appreciate the podcast. It took an interesting turn from clinical into leadership and to some backstory, but yep. It's been a really great conversation, man.
Yeah, I appreciate you, buddy. I will talk to you very soon. You're going to be in Dallas doing another keynote at our next mastermind meeting in Frisco, Texas. Can't wait to see you there. And then again in November for the next CSI course. I was hoping that you could kind of give a rundown and some dates. We do have a few seats available for the next CSI course. Maybe you can share a little bit about what that course is going to be, and the specifics for registration if people are interested.
Yeah, so we have one last course for the year, and then we're going to be pushing into 25. So I believe it's the first weekend of November, which is going to be like the 6th, 7th, and 8th, or whatever that Thursday, Friday, Saturday combo is.
Yep.
And we're going to be mainly focusing on full arch, lateral sinus grafts, block grafts, and single implants. If you want to do a couple of wisdom teeth, we have a handful of wisdom tooth docs coming in. But the main focus of this one is going to be full arch and implants. And the cool thing we're going to be doing is we're going to be letting any alumni or people who have a pretty good experience with full arch do double arches in a day. And what we do specifically for this is if you're a little bit more advanced and you're just trying to figure out how to be more efficient with your arches, like Brisky can do a double arch in 2 hours, 2 hours and 15 minutes.
Crazy.
And so it's a version of figuring out, I know it's a crazy productivity in a short period of time.
Mm-hmm.
And he does them insanely well too.
Mm-hmm.
So if it's, hey, when I do my double arches, if this is the attendee, if this is the doc, when they do their double arch, hey, it runs long. I'm exhausted at the end. We tend to have a little bit, not as much of a workflow. And you're just trying to demystify some of the areas that are holding you back. We're going to do a double arch in a day for a few docs just to show them efficiencies. Like we're going to look at your lighting. We're going to look at your posture. We're going to look at all the things that are going to subtly improve your surgeries throughout that double arch day. And then, of course, we're going to run our traditional full arches and so on and so forth. But it's going to be a really, really good one. And the November courses are always amazing courses in Colorado. So I'm excited for that one.
Yeah, I will be there. All right, my friend. Thank you so much for all that you do. Congratulations on all your success, and I'll talk to you soon.
Thank you.
All right, ladies and gentlemen, Dr. Taher Dhoon.